Good day. Good day. Now we'll discuss cyanotic congenital heart disease. Our objectives is to correctly diagnose a child with probable congenital heart disease of the cyanotic type, properly manage a child with cyanotic congenital heart diseases, and properly refer a child with cyanotic congenital heart diseases to a resident or consultant. What is cyanosis? It is a bluish tinge of the skin. It results from decreased oxygenation of the blood. When cyanosis improves when crying, it can be secondary to lung disease and disorders of the CNS. But if the cyanosis worsens when crying, it can be secondary to a cyanotic congenital heart disease. Diagnostic tests that can be done in patients with cyanosis is your Hyperoxitest. It differentiates cyanosis of cardiac in origin versus pulmonary. If the arterial PaO2 on ABG increases to 150 mm mercury, it can be pulmonary in origin. But if the PaO2 does not increase beyond this value, less than 100 mm mercury, it is cardiac in origin. Cyanotic heart disease is a defect or group of defects in the structure and function of the heart or the great vessels which is present at birth. It consists of right to left shunting in any part of the circulatory system, the atria, ventricles, or the great vessels. Cyanotic heart disease is a lesions involving predominantly diminished pulmonary blood flow that caused by the right-sided obstruction with an intracardiac communication. The common cyanotic CHD, remember the 5 T's: transposition of the great arteries, tetralogy of Fallot, truncus arteriosus, total anomalous pulmonary venous connection, and your tricuspid valve abnormalities. Transposition of the great arteries, usually this can have VSD or that with intact ventricular septum. So the blood flow is usually cyanotic because you have transposition of your great vessels. From the right side arises your aorta, which is deoxygenated, and then no mixing will happen. It goes to the left side, unoxygenated, going to your pulmonary artery. Thus, your patient is usually cyanotic. You need an interatrial ventricular communication or a patent ductus arteriosus so that there will be mixing of blood of both oxygenated and unoxygenated for the patient to survive. Physical examination in patients with TGA is cyanotic patients with normal precordial impulse. The S2 is usually single and loud. There can be murmurs or absence of murmur. And if it is present, it is usually systolic in ejection at the mid-left sternal border. Your ECG findings can be normal or can have right ventricular hypertrophy. Your X-ray is usually with cardiomegaly with increased pulmonary vascular markings. There is narrow mediastinum known as the egg on the side or the egg-shaped heart, and your 2D echo will confirm the diagnosis. Treatment is usually by infusion of prostaglandin to maintain the patency of your PDA and improve oxygenation. You can also do Rashkin balloon atrial septostomy or your BAS in severely hypoxic or acidotic infants despite your prostaglandin if surgery will be delayed. Your definitive management will be your arterial switch operation, your ASO or Giattini. It is an anatomic correction, which is the surgical of choice done within the first 2 weeks of life. Other correction is your physiologic correction, your atrial switch, your mustard or your Senning operation. Our next will discuss total anomalous pulmonary venous return. So it is an abnormal communication of your pulmonary veins going to the right side of your heart instead of going to your left side of the heart. So what are the clinical manifestations? First, it depends on the presence or absence of your venous obstruction. If the patient is obstructed, there is severe pulmonary congestion and pulmonary hypertension with rapid deterioration which occurs if no surgery will be done. Your patient is only mild to moderately cyanosis and there is usually respiratory distress. So clinical manifestation usually depends on the presence of mild or no obstruction. The patient is only mild or to moderately cyanotic or desaturated, poor feeding and failure to thrive, recurrent respiratory infections. There is signs of congestive heart failure. You have tachypnea, tachycardia, diaphoresis, hepatomegaly as the pulmonary vascular resistance falls. Systolic ejection murmur is usually heard at the left upper sternal border and your patient can have gallop rhythm. Diagnosis by ECG usually revealed right atrial enlargement or your right ventricular hypertrophy. And there is also right atrial enlargement. This is a picture of your ECG in patients with total anomalous pulmonary venous connection. And your chest X-ray can reveal Snowman sign and increased pulmonary vascularity with right ventricular enlargement. Confirmatory test is usually done by echocardiography. It usually visualizes your pulmonary veins and you can see the right ventricular enlargement, small left and atrium and ventricle, and it also demonstrates associated cardiac defects. Right to left shunting across the atrial level is also seen. Cardiac catheterization, your MRI or CT, is only done in patients with questionable drainage of your pulmonary veins. Definitive management is surgical correction. And if not be done, you can have your heart-lung transplantation for patients with veno-occlusive diseases. Next, we'll discuss truncus arteriosus. There is an abnormal, a large ventricular septal defect and a cinder trunk that arises from your ventricular septal defect. Your mixing is true by right to left shunting across your VSD, and there is only a single trunk wherein both oxygenated and unoxygenated blood will be directed to your single trunk going to your systemic and pulmonary circulation. Pulmonary venous return is usually high at birth, so the symptoms of patients is usually manifested as the drops in resistance during the first month of life, and there will be increased flow that thus heart failure ensues. Total mixing of lesion is usually complete admixture of both your pulmonary and systemic venous return at the atrial level. So your patient can present with mild cyanosis because of large pulmonary blood flow, and if left untreated, there will be pulmonary resistance increased, pulmonary blood flow decrease, thus developing Eisenmenger physiology. So what are your clinical manifestations? It varies with age and depends on the level of pulmonary vascular resistance. Newborn can have no signs of heart failure, murmur, and minimal cyanosis. At 1 to 2 months of life, pulmonary blood flow usually begins to become torrential, thus development of your congestive heart failure, cyanosis still mild with wild pulse pressure and bounding pulses. So the clinical manifestation will be mildly cyanotic child with poor feeding and failure to thrive, recurrent respiratory infections, and signs of congestive heart failure. On your physical examination, there is cardiomegaly, hyperdynamic precordium, single S2 and loud, to and fro murmur, a grade 4/6 systolic ejection murmur at the left parasternal border, and there is truncal valve insufficiency, which is a high-pitched early diastolic decrescendo murmur at the mid-parasternal border, and bounding peripheral pulses and wild pulse pressure. Diagnostic tests will reveal on your ECG biventricular hypertrophy and right axis deviation. Chest X-ray will reveal right-sided aortic arch in 50% of cases and cardiomegaly with increased pulmonary vascular markings. Still 2D echo will confirm the diagnosis, and cardiac catheterization is usually done in patients with left-to-right shunt at the ventricular septal defect and right-to-left shunting into the truncus with systolic pressure that is equal in both ventricles and in the truncal valve. How will you manage your patient? For signs of congestive heart failure in the first few weeks of life, and the definitive management will be your Rastelli procedure. You perform it in the early stage and you close the ventricular septal defect. It often needs to be repeated or enlarged because as the child grows, the child overcomes the pulmonary artery